Dear viewers, I am Dr. Ilyas, consultant radiologist at Ilyas Medicare and Diagnostic Center, and today we are here with another episode of our Pelvic Ultrasound Series. In this episode, we are going to cover basic uterine pathologies. I will confine myself to the practical points and will not go into the bookish details. If you want any more details, you can consult any textbook. But I will keep myself confined to the practical points of ultrasound. So let's move toward our screen. So let's start. The uterine pathologies can be divided into benign and the malignant pathologies. The benign uterine pathologies are fibroids, adenomyosis, endometrial hyperplasia, and polyps. I want to point out that I am not discussing I'm discussing only those pathologies which you see in your routine practice. You will daily see the fibroid, you will daily encounter with adenomyosis and endometrial hyperplasia and polyps. The rare pathologies which I do not see every day, any pathology which I don't see every day, I'm not going to discuss that case. Now coming to the fibroids. Fibroids are also called leiomyomas. These are the benign tumors of the myometrial origin and are the most common solid benign uterine neoplasms. Now they are divided into three types: submucosal, number 2 myometrial, number 3 subserosal. Uh, in your ultrasound report, it is very important to mention that what kind of a fibroid you are dealing with, because even a small submucosal fibroid can be symptomatic and maybe a large subserosal fibroid be asymptomatic and not causing any problem to the patient. And so depending upon the type of the fibroid, their management will be different. This is the image showing the different types of uterine fibroids. Here you can see that an intramural fibroid is the one which is lying within the myometrium of the uterus. Mostly it is not distorting the endometrial cavity. However, if it is of large size, it can push the endometrium anterior or posterior depending upon the from where the uterus it is arising. A submucosal fibroid is the one which is lying just beneath the endometrial lining or is indenting the endometrial lining, while a subserosal fibroid is the one which is occupying the subserosal location and just beneath the serosa. It can indent the serosa or maybe pedunculated one and projecting behind the or forward in front of the uterus. Now coming to the ultrasound appearance, fibroids are usually hypoechoic, but these can be isoechoic or even hyperechoic compared to the normal myometrium. Calcification or cystic areas of necrosis or degeneration may be seen within a fibroid, but it is not necessary. So now starting with the fibroid, this is the longitudinal image of a uterus. Here you can see the rounded hypoechoic area which I have pointed out by arrow. This is a myometrial fibroid. It is lying within the myometrium and is not indenting the endometrium, so it is not distorting the endometrial lining. Here is another myometrial fibroid. You can see it also appears hypoechoic and ectodexter and is well within the myometrium of the uterus. And in this case, we are looking at the transverse image of the uterus. Now, this image is showing large myometrial fibroids. Now I want to point out that a large myometrial fibroid can distort the endometrial lining. Here you can see that there is a large anterior wall fibroid and another posterior wall fibroid. These fibroids are of large size and relatively appear heterogeneous in ectotexture. The uterus, these fibroids are indenting the endometrium, especially the one at the anterior wall is pushing the endometrium posteriorly. I hope so that this image will explain that how a large myometrial fibroid distorts the endometrial cavity and could be symptomatic. Now, this is a submucosal fibroid. As you can see that this fibroid is indenting into the endometrial cavity. So the surrounding black portion is the fluid filled endometrial cavity and the submucosal fibroid is bulging into it. Here is another submucosal fibroid. This submucosal fibroid is pushing the endometrium posteriorly because it is arising from the anterior submucosal location. A small submucosal fibroid can be symptomatic and maybe a large subserosal fibroid be asymptomatic. Now, here is the subserodal fibroid. You can see the area behind the uterus, this large rounded structure, this is the subserodal fibroid. It is projecting posterior to the uterus and is not distorting the uterus in any way. And in most of the cases, even if the subserodal fibroids are significantly larger in size, they will be asymptomatic. So, now coming to the adenomyosis. Adenomyosis is the ectopic endometrial tissue in the myometrium. It is commonly asymptomatic, but it may present with menorrhagia and dysmenorrhea. Most commonly, it affects the multiparous women of reproductive age, and coexistent fibroids may be present in almost 50% of cases. Now, types of adenomyosis. This is diffuse adenomyosis, focal adenomyosis, and cystic adenomyosis. Diffuse adenomyosis is the most common one, while the cystic adenomyosis is the rarest. Ultrasound findings. The subendometrial echogenic linear striations or the nodule. So, in the subendometrial area, we will see echogenic linear striations extending from the endometrium into the inner myometrium, and this is the most specific sign. Then hyperechoic islands in the myometrium, then irregular endometrial myometrial junction, and a most interesting thing is the Venetian blind or rain shower appearance. These are the linear striations or parallel shadowing heterogeneous course and aqueducture of the myometrium. I'm going to show you the Venetian blind appearance in the coming images. So, image where you can see the typical linear striations. These are the linear striations which are caused by the endometrium. Other points which will differentiate on basis of which we can diagnose adenomyosis is the asymmetrical myometrial thickening. If you see asymmetrical myometrial thickening, we should think about adenomyosis. Now coming to the Doppler findings of the adenomyosis, there is increased vascularity with increased number of tortuous vessels penetrating into the myometrium, and areas of increased vascularity reciprocate the distribution of the lesions. Now, now coming to the endometrial hyperplasia, it is one of the very common findings which you will see in your routine ultrasound practice. Endometrial hyperplasia is the abnormal proliferation of the endometrial glands and stroma, defined as diffuse, smooth thickening of more than 10 mm. One of the major concern is potential malignant transformation. So the main concern when we are seeing an endometrial hyperplasia is this, that whether this is endometrial hyperplasia or endometrial carcinoma. A great majority of the patients with endometrial hyperplasia present with abnormal vaginal bleeding, and this same is the symptom in cases of endometrial carcinoma. So the main point it will be that we should differentiate in endometrial hyperplasia and endometrial carcinoma. Ultrasound findings: the endometrial thickness of more than 15 mm is considered the upper limit of normal in secretory phase. So a thickness more than 15 mm is endometrial hyperplasia in a premenopausal woman. Whenever there is a premenopausal woman, we will see that she is in which phase of her menstrual cycle, because the endometrial thickness keeps on changing. But if the endometrial thickness is more than 15 mm, then whatever the phase of the menstrual cycle, we will call it endometrial hyperplasia. In the postmenopausal woman, a thickness of more than 5 mm is considered abnormal. And as I have mentioned earlier, the appearance can be non-specific, and we cannot reliably differentiate between endometrial hyperplasia and carcinoma in a postmenopausal woman until unless we have specific appearances. But it is said that if a female who is postmenopausal is having a more endometrial thickness of more than 5 mm in with the symptoms, she should be examined, and it should be considered an endometrial carcinoma until unless proved otherwise. Now, here you can see that endometrium is thickened. The endometrium, which appears hyperechoic in texture, which is its normal appearance, but it is significantly thickened. It is more than 15 mm, and it is smooth in outline. We can see that there is no irregularities of the margin of endometrium. So we will consider it endometrial hyperplasia. There can be cystic change also. With endometrial hyperplasia, there may be some cysts within the endometrium, and it is a good sign that it is endometrial hyperplasia. Here again, you can see that there are many cysts within the thickened endometrium. Now coming to the endometrial polyp. Polyp is also a very common finding which we'll see in your routine practice, and one of the very common findings in symptomatic patients. Endometrial polyps are benign nodular protrusion of the endometrial surface, and one of the entities included in differential of endometrial thickening. So whenever there is thickened endometrium, basically we have to differentiate between three things: endometrial hyperplasia, endometrial polyp, and endometrial CA. Endometrial polyps can be either sessile or pedunculated. Most polyps are asymptomatic, although they can be common cause of postmenopausal bleeding, and they can lead to menorrhagia or infertility. Now coming to the ultrasound finding: solitary, homogeneous, and echogenic. I will repeat: solitary, homogeneous, and echogenic lesions. A stalk to the polyp may either be thin and we will call it a pedunculated, or it can be a broad-based polyp also. Now there are some specific signs which a polyp shows. Interrupted mucosa sign: the endometrial polyp focally interrupts the normal mucosal contour of the uterine cavity. It may be surrounded by the endometrial fluid, and the most important sign is the feeding artery sign. On Doppler imaging, a single feeding vessel may be seen extending to the polyp. Now coming to the images, here you can see that the endometrium is clearly outlined, but there is a focal hyperechoic mass filling the endometrial cavity. This is the endometrial polyp. The rest of the endometrium is hyperechoic but not that much. And secondly, they are smooth. The rest of the endometrium is smooth in outline, but here is a focal bulge. Whenever there is a focal bulge in the endometrium, the polyp should be the first differential. Here you can see on the transverse image of the uterus, the wide arrow points out the feeding vessel, and here on the Doppler imaging the feeding artery sign is shown, while the narrowed arrow is the polyp, body of the polyp. Now coming to the malignant uterine pathologies. The only malignant uterine pathology which you will see in your routine, I'm again saying, in your routine clinical practice. It may be if you are working in a cancer hospital, you will see a lot of other things. But if looking at your routine clinic, the only pathology, malignant pathology, uterine pathology which you will see will be endometrial carcinoma. It is the most common gynecological malignancy, and it frequently presents with vaginal bleeding. Now coming to the ultrasound findings, endometrial carcinoma usually appears as thickening of the endometrium. So we have discussed three things: endometrial CA, endometrial hyperplasia, and endometrial polyp. All these are appearing as thickening of the endometrium. But the differentiating point is this, that the endometrial hyperplasia, it is smooth. In case of endometrial polyp, there is focal thickening. Exceptions are always there, but I am talking about the routine points. And in case of endometrial carcinoma, if there is a postmenopausal woman with symptoms with more than 5 mm endometrial thickness, we will consider it endometrial carcinoma until unless proven otherwise. And if it is a postmenopausal woman without symptom is presenting with more than 11 mm endometrial thickness, we will consider it an endometrial CA until unless proved otherwise. So whenever there is a patient with these kind of symptoms, she should go for diagnostic DNC. The endometrial CA is usually not seen in premenopausal women. Features favoring malignancy: heterogeneous and irregular endometrial thickening. As we have seen in the endometrial hyperplasia, there is smooth endometrial thickening. Then there could be frank myometrial invasion. Then there could be disruption of the subendometrial hollow on the ultrasound, and this signifies a myometrial invasion. Then we should keep it in mind that endometrial hyperplasia or endometrial CA is a histological diagnosis. It cannot be differentiated from early stage endometrial carcinoma and early stage and endometrial hyperplasia. Most of the time they cannot be differentiated. on ultrasound. So whenever there is a suspicion, we should go for histopathology. Postmenopausal bleeding is an important clinical sign for risk of stratification of image findings. If postmenopausal bleeding is present, more than 5 endometrium should be histopathologically examined, and if it is not present, then endometrium of more than 11 should be proposed for histopathology. Now, here you can see that endometrium is thickened and it is irregular in shape. There is fluid in the endometrial cavity, and there appears to be multiple lobules like structures projecting into the endometrial cavity. This is a case of endometrial CA. Here is another case of endometrial CA. It's a post-menopausal woman, and you can see that endometrium is markedly thickened, and especially along the posterior wall, the endometrium myometrial interface is not clear. In the arrowhead of the, you can see it at the arrowhead of the posterior wall. So with this, we came to an end of this episode. In the next episode, I'm going to cover the ovarian pathologies, and in the same manner as I have done in this episode, I will keep myself confined to the basic practical points which we see in our routine clinical practice. Thank you so much. Please do like, comment, share, and subscribe. Allah Hafiz.